Welcome, my name is Dimitris Karavias. I'm a locum HPB consultant at the University Hospital of Southampton. This is a brief overview on acute pancreatitis, and as before, this presentation was made possible with the invaluable help of Mr. Arjun Thakkar, who's a consultant HPB surgeon and senior lecturer at the University Hospital of Southampton. Hopefully, by the end of this presentation, you will know about the epidemiology behind acute pancreatitis. You will have learned the most common causes of acute pancreatitis. You will be able to identify the symptoms of these patients. You will familiarize yourself with the different severity scoring scales, and you will feel confident in managing these patients both in the A&E and at the wards. Finally, we will discuss some of the complications and how to treat them. And briefly at the end, we will discuss the NICE guidelines. Acute pancreatitis is an inflammatory process of the pancreas caused by enzyme-mediated autodigestion of the gland. It is mild in 75% of the cases and usually resolves spontaneously between a few days and a couple of weeks. However, in 25% of the cases, we can have severe life-threatening disease. The incidence of acute pancreatitis in the United Kingdom has increased over the last 40 years. It ranges from 150 to 420 cases per million population. It has a considerable geographical variation. It is, however, a very common cause of acute abdomen requiring hospital admission. The pancreas sits in the middle of the abdomen on top of the great vessels, and it is surrounded by the stomach and the duodenum. It is connected with the gallbladder and the biliary tree, where the pancreatic duct joins the common bile duct, and they both drain in the ampulla of Vater. The pancreas essentially has two roles, an exocrine function and an endocrine one. The exocrine function produces all the digestive juices that help digest food, primarily by regulating the production of pancreatic amylase, trypsin, chymotrypsin, and carboxypeptidase, the pancreatic lipase, and ribonucleases and deoxyribonucleases. The endocrine function controls the homeostasis of glucose in the bloodstream with the production and regulation of glucagon and insulin, and also regulates the digestive function by the production of secretin and CCK. There are several causes of acute pancreatitis. However, the most common ones in the UK are either gallstones or alcohol. There have been several mnemonics to help you remember all the different causes of acute pancreatitis. However, I believe that the mnemonic I get smashed is the easiest to remember. The most common causes are idiopathic, gallstones, and alcohol, as we already discussed. Trauma can also lead to acute pancreatitis, different steroids, mumps and malignancy. A lot of the times we have autoimmune reasons. Even very strange things like a scorpion bite and sting can lead to acute pancreatitis. Hypercalcemia and hypertriglycemia can also be a very relevant cause. We can have acute pancreatitis after endoscopic procedures like an ERCP, and as always, there are several drugs that can lead to acute pancreatitis. Most of the patients present with epigastric pain that typically radiates to the back. They can also have associated nausea and vomiting. If we have gallstone pancreatitis, then they can also present jaundiced. They might have a low-grade fever, and a lot of the times they have tachycardia. The diagnosis is typically made from the presentation. As I said, patients present with abdominal pain that typically radiates to the back. However, the diagnosis is definitive when we have raised serum amylase or lipase, and also from the bloods you can see raised inflammatory markers like white blood cells and CRP. On imaging, Typically, in the early stages, we will see an edematous pancreatic gland, and also we can essentially identify a possible cause when that's, for example, gallstones. Typically, patients need an ultrasound scan to confirm or exclude the presence of gallstones, and usually they might require a CT scan or an MRCP, not definitely in the early stages, but ideally within the first 72 hours of admission. The most important thing for patients presenting with acute pancreatitis is monitoring them. There are several different scores, however, the one that has been validated and is widely used is the NEWS score. Apart from monitoring, there are several different scoring systems that can help you classify whether a patient has a mild or a more severe pancreatitis. A very common scoring system is the Ranson criteria, which are essentially calculated on admission and then scored at 48 hours. If the patients have up to 2 of these factors, the mortality is less than 3%, and if they have over 5 to 6, then the mortality can reach up to 100%. An easier scoring scale is the Glasgow score, or as it's known, the modified Glasgow IMRI score, which has a very convenient mnemonic to remember all the things you need to measure, which are PO2 less than 8, age above 55 years, neutrophilia with white blood cells over 15, calcium less than 2, renal function with urea of greater than 16, liver enzymes with an LDH over 600 and an AST over 200, albumin, serum albumin less than 32, and sugar with blood glucose over 10. When the patients have more than 3 of these factors, then we are discussing about severe pancreatitis. Another scoring system that it is very relevant, but it's not just for acute pancreatitis, is the Apache 2 score, which is essentially a classification regarding severity of patients admitted in the ITU. It is a point score that is calculated from the patient's age and 12 routine physiological measures, including PO2, temperature, blood pressure, pH, heart rate, respiratory rate, and a lot of measurements from the blood test, and finally the Glasgow Coma Scale. What we most commonly use nowadays is the revised Atlanta criteria, where patients are classified in 3 groups. Patients that have mild pancreatitis, when you don't have any organ failure like shock, hypoxemia, renal failure, or gastrointestinal bleeding, when they don't have local complications like pancreatic necrosis, pancreatic abscess, or pancreatic pseudocyst, and no systemic complication. As previously said, using early prognostic scores or signs like the Ransom score of 3 or greater and the Apache 2 score of 8 or greater are imperative for scoring these patients. Moderate pancreatitis is when you have transient organ failure that lasts up to 2 days with some local complication or an exacerbation of comorbidity. And finally, severe pancreatitis when you have persistent organ failure for more than 2 days. The management, we tend to keep patients nil by mouth at least for a very short period of time. You need to realize that all these patients need aggressive fluid resuscitation. If they can tolerate oral fluid, that's great. If not, we need to support them with intravenous fluids. We need to supply and offer them adequate analgesia, and a lot of the times we need the assistance of the pain team or the anesthetics with PCA pumps. And finally, we need to monitor their fluid balance, either with collecting urine or with placing a urine catheter. The nutritional support has changed over the recent years. In the past, we used to starve these patients for days, if not weeks. However, now we know that early oral feeding, even within the first 24 hours, is recommended as tolerated. If the patients cannot tolerate oral nutrition, then we need to support them either with enteral nutrition or with a parenteral nutrition. Ideally, we know that patients do better when they are offered enteral feeding, either with a nasogastric or a nasojejunal feeding tube. Most of the patients will do great with just supportive management. However, there is a subgroup of patients that might require early interventions, and usually these are the patients that present with gallstone pancreatitis. We might need to offer an early endoscopic sphincterotomy, ERCP and stone extraction for patients presenting with severe biliary pancreatitis and a blocked system, or an urgent ERCP in patients presenting with acute cholangitis. Finally, for patients that have gallstone pancreatitis, we need to consider offering them an elective cholecystectomy during the same hospital admission when they only have mild biliary pancreatitis. There are several complications like an acute pancreatic fluid collection, pancreatic pseudocyst, pancreatic necrosis, hemorrhage, or pancreatic ascites. Pancreatic collection is essentially an acute fluid collection usually around the pancreas. Typically on the CT scan, if the patients have an early imaging, the radiologist will tell you that there is a lot of pancreatic edema with peripancreatic fluid. Usually this happens within the first few weeks, and the fluid is not organized or encapsulated. Most of the times we don't have to do anything about it, and it usually resolves spontaneously as the patients recover. However, if these collections persist, then we can end up with a pancreatic pseudocyst, which typically present after or develop after the first 4 weeks. Typically on a CT scan, the radiologist will comment about an encapsulated fluid collection, either peripancreatic or somewhere in the abdomen. Pancreatic pseudocysts also can resolve spontaneously. However, if they are symptomatic, then they will require drainage. The most typical symptoms is you have big pseudocysts that either cause gastric outer obstruction or compressing other organs. Ideally, if the pseudocysts are matured enough, we strive to drain them endoscopically. Pancreatic necrosis is the most serious complication. You can have an acute necrotic collection or one that develops over a period of time with walled-off necrosis. It can contain fluid or solid material, but most of the times it has mixed components, especially as the disease progresses. It can again be intrapancreatic or peripancreatic, and it can be sterile or infected. As you can see on this scan, we have a big pancreatic necrosis, essentially replacing most of the body and the tail of the pancreas, and I would suspect that this is an infected pancreatic necrosis because it contains a lot of gas. The thing that you need to remember is that pancreatic necrosis evolves over the admission or the first few weeks. So initially, as we discussed, we have a patient that has a big peripancreatic collection, as in this scan, where most of the pancreas has been replaced by a necrosis, and this necrosis evolves, and by week 3 we can see that essentially all the pancreas has been replaced by this necrotic tissue that causes problems or compression to adjacent organs. The management, ideally nowadays, for pancreatic necrosis should be minimally invasive. We can put a percutaneous drain, we can do a video-assisted retroperitoneal debridement, we can still do surgical debridement, or ideally we should do an endoscopic, transgastric or transduodenal drainage. Briefly, percutaneous drainage usually are available or offered to patients that have an acute collection or necrosis in a very early stages, where these collections cause problems, and we need to essentially drain them in order to help the patients. The most common problem with a percutaneous drainage is that essentially the patients will end up with a pancreatic fistula that can be a very difficult thing to manage. Over the last few years, video-assisted retroperitoneal debridement has gained a lot of attention and popularity. What we do essentially is do a retroperitoneal, usually left flank percutaneous drain, and when the necrosis has matured enough by week 4 to 5, then we surgically upsize the drain under guidance to a size where it can accommodate essentially a nephroscope that we can go in and wash all the necrosis over a few sessions in theaters. Surgical debridement used to be very popular in the past. However, a lot of patients used to have surgical intervention at a very early stage, and the results were quite bleak. The mortality rate was significant, in excess of 50%, and for the lucky few patients that survived such an intervention, they would end up with open abdomens, massive abdominal hernias, and a lot of problems, and usually the hospitalization ranged from months to a few years. Nowadays, the gold standard is to do an endoscopic drainage. As I said, the endoscopists can either drain these collections through the stomach or through the duodenum. The main problem is that the necrosis in the collections have to be matured enough and walled off. So usually we reserve the endoscopic drainage after the first 4 to 5 weeks. The endoscopist can use either plastic stents to keep the cystgastrostomy open, or use the hot axial stents like the one you see in the CT scan, and they can use them as an access to go back every few days to wash all the necrosis out. The NICE guidelines advise that we should offer all patients that had an acute pancreatitis lifestyle modifications, like advise them to stop alcohol or stop smoking. We shouldn't offer prophylactic antibiotics to these patients unless we have an infected necrosis. As always, we need to remember that these patients most likely require aggressive fluid resuscitation, and regarding the nutritional support, early oral feeding is advisable as tolerated, and if not, then we should consider enteral feeding within the first 72 hours. If that's not possible, then a TPN is an alternative, and if we have an infected necrosis, ideally we should consider an endoscopic approach when feasible, or if the patients are acutely unwell, then we can consider an percutaneous drain, essentially if the necrosis is an odd place which is not accessible endoscopically. To summarize, the most common causes of pancreatitis are gallstones and alcohol. Typically, patients present with epigastric pain that radiates to the back. You have raised serum amylase or lipase, which is diagnostic. Close monitoring is essential, and most of the time management is conservative, with fluid resuscitation, analgesia, nil by mouth initially, with an effort to restart oral nutrition early as tolerated. There are multiple severity scoring systems, and the most common complications are an acute pancreatic fluid collection, pancreatic pseudocyst, or a pancreatic necrosis, and ideally the management of these complications should be endoscopically or minimally invasive. Once again, I would like to thank you. You can test your knowledge with the questions below, and we would be grateful for your feedback. As always, you can find our videos on YouTube, but I would also like to remind you that you can visit our website for more related content. Thank you, and see you again in the near future.